Welcome to our third and final part in our series of NRP review. My name is Lisa. I'm an experienced NICU nurse, a NICU nurse educator, and I have been an NRP instructor for 7, almost 8 years. So we've done part 1, we've done part 2, and now we're ready for part 3, which is the most extensive part of resuscitation, and that is medications and lines. So we've already intubated, we are doing our chest compressions. It is now time to give epinephrine. In a delivery or in a NICU on a baby that doesn't have access, most likely you are going to be giving epinephrine via the ET tube first. In the 8th edition, we standardize our dose. We're giving 1 ml per kilo of epinephrine down the ET tube. It goes in the ET tube, you bag it in. In this week's YouTube video on part 2 of NRP, we talk about how it's absorbed, so go watch that. It will help you with that. If you have access, you would give 0.2 mils per kilo of epinephrine via the IV and follow with a 3 ml flush. So that's key takeaway 7 and 8. Number 7 is the dosing. Number 8 is that we give the 3 ml flush. The last thing about epinephrine is that if you have given an ET tube dose of epinephrine and it is not your standard 3 to 5 minute change to give another dose, but you get access, you can give another dose of epinephrine via a different route immediately. And that is because it is absorbed differently. So that's our epinephrine key takeaways. Other medications that we give during resuscitation is going to be volume expanders in the form of normal saline or blood. Both of those are given as 10 mils per kilo, rapid push over 5 to 10 minutes, which is very different than when we do in the NICU. I remember the first time I had to do that, I was scared, very much so. In the NICU, we give our boluses over 30 to 60 minutes. We give blood over 3 to 4 hours. In a delivery, you are going to push your 10 mil per kilo bolus of normal saline or blood over 5 to 10 minutes. And that's because this is an emergency and we need to get this into the baby. So that is your key takeaway about fluids. And then your UVC, the key takeaway about your UVC is it has to be put in by someone that's trained. Could be a transport nurse, could be a vascular access nurse, NRP fellow, etc. It goes in just until they get blood return. We're not sitting around waiting for x-ray. It's not the most sterile thing you've ever seen in your life. And the baby's probably going to get a dose of vancomycin if they get an emergency UVC placed. Goes in until they get blood, and then you can start using it right away for your fluids, medications, etc. That's everything we covered. I'm going to do a recap video where we go through every single key takeaway, but these are what you should be referencing if you have any questions about NRP.